Good evening and welcome. It's now 6 o'clock. I'm handing over to Dr. William Westhuizen. Thank you.
Thanks so much, Renew. Good evening, everyone. A very important webinar tonight. The president has found his pen. I think you've all heard the news. I assume it was a Mont Blanc rather than a Bic. I've got the pleasure of introducing our chair of the association, Dr. Mzukwa, to say the opening words. Dr. Mzukwa, over to you.
Thank you very much, William, and good evening, colleagues, and welcome to this evening webinar. As the ink dries on the National Health Insurance Bill, SAMA continues to express its profound concern and opposition against the NHI in its current form. As it stands, it fails to adequately address the critical socio-economic imbalances and inequalities of the past that continue to plague our health system. While the intention of the bill is to transform our healthcare system, it is commendable. The implementation strategy lacks the necessary depth and practicality required to achieve meaningful and sustainable change. For one, the funding mechanism is flawed in its heavy reliance on general tax revenue, the payroll tax, and surcharges on personal income. Not to mention systems and structural challenges such as ethical governance and leadership and poor human resource allocation. It is clear, colleagues, that the NHI is not a viable solution to realize universal health coverage for the South African population. We had hoped and remained optimistic that the president was going to refer the bill back to Parliament for further stakeholder engagement, to assist with insights and expertise with the aim to resolve the challenges the bill will pose, and to bring all parties and the country closer to realizing universal healthcare in our lifetime. Sadly, these calls for a better healthcare system were ignored. As the South African Medical Association, we believe that it is our duty to advocate for equitable access to affordable essential healthcare services. And it is a cause that we are ready to fight for. In protecting our healthcare services, SAMA's legal team is preparing to launch this challenge in relevant courts in this country. But to talk more on the legalities and the important updates of our healthcare system, I will refer you back to Dr. William Westhuizen to really introduce Ms. Elsabė Klinck. Thank you so much.
Thanks so much, Chair. And rest assured, everyone, we've been preparing for this months in advance, if not years. I've got the great pleasure of introducing Elsabė, a key member of the legal team that will be challenging the bill. Elsabė Klinck, and I think most of you probably know her, is the managing director of Klinck Samuels. She specializes in health law, policy, and ethics. She's been involved in the sector for more than 24 years. Prior to her health sector involvement, she was a senior lecturer in constitutional law, which is quite relevant given the circumstances. She's also been involved with the Center for Human Rights Studies. Elsabė has published numerous works. She's spoken widely on these exact topics, and she holds degrees in law, German, and applied psychology. That's good as well. And she lives in Hermanus with Louis and 2 unruly Labradoodles. Elsabė, over to you.
Thank you, William. Let me just share my screen. Great. Good. So I have titled tonight's talk NHI Law and Narratives, because I do think the space is dominated by narratives so far. And as we move into this next phase, I think we may be pulled back a bit to the legal aspects of this. The narratives are important as well, because it is, after all, about all of our healthcare. So my presentation split in two. There's not many slides so that we have maximum engagement. But the first bit is on what is in the bill. And I do think it's important that people look at the bill and understand how it is comprised and what is in there. I must actually not stop talking about it as a bill. It's now an act of parliament. And the second bit then is a bit about the narratives. So what is in the NHI Act? The first thing is who will be covered, and that's what everybody is asking. And there's lots of people that say various things. And I think we need to always go back and say, it basically says South African citizens, permanent residents, refugees, inmates, and then there's this category where the Minister of Health, Minister of Finance, and the Minister of Home Affairs could decide other categories of non-South Africans. So a very good case in point, the disaster in George. If we had NHI, the question would be, would all of those workers be covered by the NHI fund? Because remember, compensation fund would then be rolled into the NHI fund. So, and that would then depend on a determination such as this. And then illegal foreigners and asylum seekers would only have access to emergency medical services and then notifiable conditions of public health concern. So that would, for example, include TB, but not HIV. So that's the first important bit. The second important bit that I think affects SAMA's membership tremendously is the fact that the bill is structured around 3 buckets for contracting. So there's primary care contracting, then there's specialist and hospital services rolled into one. So in the public sector, that makes sense. In the private sector, not so much, because the private hospital and the practitioners are in different legal entities. And then emergency services. It's also for the entities to whom SAMA's members may be referring, or entities that they use, such as blood services. It's not clear in the bill how that would work and where they would fit in. If we think about orthotics can actually happen, and prosthetics could happen in all 3 of these buckets. So an OMP that contracts, the question is, how would they contract and how would their income be calculated? Because the remuneration for primary care would be on a capitated basis. For specialist and hospital services, it will be an all-inclusive fee. So presumably the private hospital would then get a fee and would then need to divide that. And that in turn raises issues in terms of practitioners who are not hospital-based or who see a whole range of their patients outside of the hospital setting as specialists. And then emergency services on a case basis. So related to this is another important section in the Act, and it is the accreditation. So one would not be allowed to contract into the NHI if one does not have the necessary accreditation. So, and that means being registered at the relevant body, nurses at Nursing Council, doctors at HPCSA, etc. Then being accredited by the Office of Health Standards Compliance. And this is one of the things that I think will put brakes legally on the NHI, because we know that the Office of Health Standards Compliance at this stage is accrediting private and public hospitals and public sector clinics, but is not accrediting private medical practices, for example, or physiotherapy practices, or any of those for that matter. So, and as far as I understand, the standards for GPs have been are far advanced, but I'm not sure how far the standards are for other practitioners, occupational therapy or so on. And then one would need to submit what the bill calls a budget impact analysis. It's not clear what that is and what will happen to that, because if all practices in the country, and if we count the practices, there are tens of thousands of practices of places that could potentially be contracted in. The question is, who will evaluate all their budget impact assessments, and what exactly would that be? Then one would need to provide the services as prescribed by the minister. So that's not clear yet. So one would need to wait for regulations to say, but the Act doesn't give us any hint as to what these services could be. One should have the number and mix of professionals as prescribed. So it could potentially say that if a hospital is contracted in, that they need to have in this bucket through which they contract, they need to have certain specialists, certain supportive professionals like OTs and physios and so on. But that's also, we're not sure as to what that would be. Then one would have to adhere to treatment protocols and guidelines. And one would be obligated to prescribe and procure goods from the NHI funds lists. So it seems to be very strict, and there's other sections in the Act that actually talks about one being kicked off the system if you are not adhering to that. One has to adhere to referral pathways. One would have to submit information to the National Health Information Service. And then one needs to adhere to the pricing regimen. And this, for me, it's interesting because lawyers don't talk about a pricing regimen. It's a typical medical term. So, but this pricing regimen, which in turn then imply a price regulatory, price fixing type of system. So these are basically then the criteria to be able to contract, to be accredited in order to contract into the NHI. So what politicians have been saying, you can just clock in at either facility, a public or a private facility. It's not as easy as that. That facility that you've clocked into would need to be accredited and contracted to the NHI fund. And that means the NHI fund would need to be in existence. And that we've heard today is probably going to take another 3 years to create this fund, this structure. So for the public hospital and public facility setting, one of the key components is what is called a function shift. So whereas healthcare would have been in a provincial setting, it would be controlled by the province, and the facilities would resort under the province, that function would shift to the national government and the facilities in the public sector. So the district health management organization, central hospital, tertiary hospitals, they would all become national government components. So this is significant also for SAMA's public sector members, because it does then imply a change in who the employer is and who controls how healthcare is rendered in that entity. And I'll talk a bit about that when I talk about the narratives. So this is also the big discussion point. How will it be funded? It's all in section 49. And the first is this shifting of funds. And what I've just said in terms of national components, this follows on that, because if we move the power away from a province, the money would need to follow. The other funds that will shift, I've already alluded to, is, for example, the healthcare funds and the compensation fund. So this shifting of funds is already outlined in the NHI Act. Then the medical scheme tax credit, the wording here is a bit odd because the tax credit is not given to the medical scheme. It is a credit that people get to pay a little bit less tax because you belong to a medical scheme. But be that as it may, the idea is that that would be scrapped. Then a payroll tax. and a surcharge on personal income tax. And it's also these last two that are going to affect the average person. Those laws, this would need to be done, the details of this in a so-called money bill, which we haven't seen yet. And it does seem that it would be the first bit, so the shifting of funds that would take place first. So taking the health money from the provinces and putting it in the NHI fund, and then creating these autonomous or semi-autonomous components of national government in terms of where the hospitals are residing. Then it's not only about the healthcare and the funding of the healthcare or the administration thereof. It's also the costs of setting up the structures. So if you read the NHI Act, you'll see there are 3 chapters that creates new structures for the NHI fund. And then in section 57, there are certain other committees and structures that are set up in the interim in view of the final processes and the final NHI fund. So it will create a fund with a CEO, a board. There's specific mention of one of the units, a procurement unit, and of course staff for all of this. Now, some of the staff are already appointed as part of the current National Department of Health's website. And if you look on their website under NHI, it's all outlined there, and you can see, for example, medicines pricing and pharmaceutical procurement is already shifted into that technical component, and those staff are heading up those units. Then there's 3 advisory committees with people, so there's a cost associated with that, getting people to meet, appointing them, all of the costs around those committees. Then a thing that's going to be a massive aspect of the NHI fund is this complaint system. So we know the Council for Medical Schemes currently runs a complaint system, and there is a complaints and an appeals tribunal. So that also needs to be funded. The operation of that, the technicalities around that, the processes would need to be funded. Then, because there's so many powers that the minister has, for example, the minister would in the end approve the formularies, this power to decide whether, people who are not South African citizens or permanent residents, whether they can be covered. All of those powers would require technical assistance at a ministerial level to help the minister exercise these various powers. Then there's ministerial advisory committees that are envisaged on at least health technology assessment in terms of section 57, and then healthcare benefits. And then, of course, creating the National Health Information Service and electronic medical records is also costs that need to be costed. So people talk a lot about rendering the care, but we forget about the rendering the care, the administration of that, and then these structures and the costs thereof. Some of it is being budgeted for in the current NHI grant, and some comes from the National Department of Health budget, so for the pharmaceuticals and so on. And then if you need a bit more details, you can look in the budget speech and also in the National Department of Health's annual performance plan. There are some details on this. But because we don't have an updated costing of the NHI, this bit, we're not sure exactly how it's been costed at present. So what will it cost us to run everything that's on this slide? Okay, so let's get to the narratives. So one of the most important things, and we've tweeted about it today, is that we actually already have NHI for primary care, free at point of care under the existing National Health Act. So we've got that. So the only people who are not benefiting from that are medical scheme members and people who are receiving compensation for compensatable occupational diseases. So in the NHI, the only change would be is we're bringing those people then into the NHI system. But for the rest, we already have it. So, and many people, this has elicited quite a lot of discussion that if we already have this for primary care, what is going wrong? Why is it not working? Why isn't it working as it should? The second narrative, and this is something people that know me well, it's absolutely, it's a huge thing, because what we do, if we talk about this, we equate the medical scheme population to the only people who are receiving private sector care, who are seeking private sector care. Now, the household survey shows us a different picture. And the SAMA members who practice throughout the country, SAMA's own research have shown that private practices see a significant number of patients who are not medical scheme members. So to say that the private sector is an elitist, self-serving entity that only serve rich people is not correct. And I think we have to work to dispel this myth, because there are people out there who are actually seeking healthcare and providing healthcare in the private sector. And this is why one should be leveraging the private sector. So the other narrative is that we don't know yet how much we're going to pay in these contracting buckets, those 3 buckets that I spoke about. So we shouldn't be criticizing it because perhaps we get paid brilliantly. And because there will be more volume, and because like these private practitioners who are seeing non-medical scheme patients, that patient will probably have a better fund behind them to cover their healthcare. We would be better off. What we do know, however, is that taxes cannot be raised in the meantime. And National Treasury has confirmed that last week at the BHF conference. The public sector at present spends 5,000 rands per head per year on healthcare. The private sector, 25,000. So if we want to create an average of 9,000, it means we'd need to start taxing, but we cannot start taxing. So it looks as if with these shifting of functions, as if we're not going to have more money per patient in the NHI fund before we start taxing. And that then means, and even if we do start taxing, the 9,000 is a lot less. And the promise of volume to say, we'll pay you less because the envelope per patient is now thinner, we'll pay you less, but you can see more patients is something that is problematic for doctors who say, I already am at capacity. I cannot see more patients. And that made me think of the presentation on the NHS last week as well, where the presenter said, you know, that doctors had to see patients, GPs had to see patients with 6 minutes per patient. And I think that's, practitioners feel very uncomfortable with having to do volume, but not necessarily ensuring quality of care. Then the question, the fact that taxes cannot be raised at present is a big concern. So we'll just shift the monies. So that's that first part of Section 49. So this means that the provinces will no longer have control over healthcare. And if you read the schedule to the Act, and many people, the Act just says these sections are scrapped. If you look at what is being scrapped in the National Health Act, it removes provincial control, management, and planning for health services. So, and because that's removed, the money is removed, it does affect the way in which we've organized healthcare so far. So it also means that staff will no longer be employed because there won't be money to employ staff with. And it means that numbers of staff, so if the provinces remain these agents, they would need to have some staff to do managerial things. But human resources in terms of healthcare professionals would then have to move to the facilities, to these components of national government, as I've shown in that one slide with the 3 arrows. Then currently we have 9 provinces having control over the district and the hospital. So you've got 9 head entities, if you can call them that, that's looking at the 52 districts and 374, it's 3,741 facilities. So if we say we make them components of national government, the oversight is one entity having oversight legally over all of these entities. And to me, that seems like a huge burden in terms of not being able to say the province would have that power. So that's then the end of my narrative on this. I thank you, and I look forward to questions.
Thanks so much, Elsabė. We've deliberately left a lot of time to get to the questions. I think one of the first questions that's come through, this is from Dr. Hatruit. Will SAMA be cooperating with other stakeholders in these legal battles that seem to be on the horizon? And of course, some of these stakeholders that have indicated that they might also turn to the courts or other associations, medical funds, etc.
I think that's a question for SAMA.
Well, we definitely foresee that many of these cases will be consolidated into one. I think many similar arguments will be raised. Many similar issues would need to be sorted out. Here is clear constitutional friction. And in that regard, I do think that there will possibly be some cooperation between the various legal teams. Of course, our case looks different than Discovery's case or one of the funders' cases. We are concerned about our members, the profession, the health system, and I suppose most importantly, and this probably goes against the narrative out there, our patients. We're really concerned about them and what NHI means for them. So it's critically important for us to just consider all of those factors. Another question here from Dr. Lowe is, has anything been done about the medico-legal burden? And he indicates that this will certainly destroy any NHI or any other model of healthcare that is planned. Where is the government currently on that, Elsabė? And is anything said about that in this NHI Act?
Yes, so that is such a good question, because this is one of the things that, although it was raised through the parliamentary processes, was not adequately addressed. We know that medico-legal, the contingent liability in the provinces are massive. It's equivalent roughly to the budgets of all 10 central hospitals. So it is a huge amount of money. And the other important thing is, if we shift these functions, that legal liability stays with the province, so that existing liabilities stay. The other thing is, if we make these entities components of national government and somebody sues, for example, Tembisa Hospital, it could decimate their budget. So that's on the side of being sued and having that liability. On the side of professional indemnity and who needs to take out that indemnity? And if you are, as I said, as part of your accreditation, you must stick to formularies, referrals, and all of those things. Who would pick up the medico-legal premiums, the cost of insuring or covering against the risk that could come from providing services to NHI patients? So that is not clear at all. So it is a very important bit. What I found interesting is that the annual performance plan of the National Department of Health, although it deals with it in introduction in terms of specific targets and actually implementing the Law Reform Commission's report, which we all want, because there is an issue with medico-legal liability. There is an issue with the law of delict and criminalization of healthcare. We need to address that, and just from a funding perspective and what it could do to the NHI as a fund. But also it is one of those things that we cannot say we're doing NHI now and we're forgetting about that objective, because it is very important.
No, quite right, Elsabė. And just reading through the questions, there's a lot of uncertainty and I suppose a lot of understandable anxiousness amongst our members. One of the questions that comes up quite often is, will private health still be allowed under the NHI, or will it be outlawed?
Yeah, so I think private healthcare as service providers is secured in those contracting buckets, although we've got criticisms against that. But there is an acknowledgement that the health sector cannot work without the cooperation and collaboration of the private healthcare sector. It's a different matter for insurers, for medical schemes, because on that front we know, and that's the big battle that the medical schemes are fighting, is Section 33, that says once the NHI is fully implemented, medical schemes will not be allowed to cover things that are covered by the NHI. So if the NHI covers hypertension, medical schemes can't cover it, for example. But the why this is not an immediate crisis, and you would have seen those communications from medical schemes coming out, is that Section 33 says once the NHI is fully implemented. So, and we know it will be incremental, not all the sections in the Act, and I think that's perhaps important to emphasize. The Act is not in force yet. It's now on our statutes books, it's been assented to, but the various sections have not been proclaimed. And that process will take place over time. It won't happen overnight. And although there's these other things that are happening in terms of what the accreditation framework would be, that's happening behind the scenes. Nothing can be implemented as the NHI before the various sections haven't been brought into effect by proclamation by the president. So the next time when the president grabs his pen, it will be to proclaim some of the sections. So I also want to say to people, don't panic. We need to be active. And we need to be active in our healthcare. We need to talk about more efficient business models, how we should render services, how should we deal with the HPCSA changes to the ethical rules. We've got a lot to keep ourselves busy whilst all of these other things play out and the court cases play out.
Another interesting question that's raised in the chat is, what if a doctor refuses to join and sign a contract with the NHI and sign up to its rates?
Yeah. So there's no enforcement mechanism for that. So nobody can force anybody to sign up and contract. So first be accredited and then contract into the NHI. However, if the NHI is fully implemented and medical schemes, for example, cannot render diabetes, hypertension, and those conditions, the theory was, and this we've known since the green and the white papers, the theory is that practitioners would have no choice. To survive, you'd need to contract, unless you're going to do lots of dermal fillers and plastic surgery and things that will be excluded from the NHI fund. But that's, so nobody is forcing anybody to contract, but if you read the policy documents, the hope was always that practitioners would contract and that there wouldn't be a large scope after the NHI is fully implemented to opt out and have a viable practice.
Yeah, no, I mean, scary stuff. The employment of doctors. Recently, the HPCSA ethical rules have been amended, making provision therefore. But what about the employment of doctors at hospitals, or how do we foresee that progressing under the NHI?
Yeah, so Ethical Rule 18 has been amended, so it's possible for a hospital to employ doctors. And this is why that middle bucket logically would make more sense if the hospital contracts with its full employees, you know, so with a surgeon, an anesthetist, an ENT, GPs, everybody employed, physios, OTs, the whole shebang, dietitians. So it is possible in law now for a hospital to do that. So one, to the extent, I'm not sure to what extent that will be taken up by hospitals. We've seen it in units. We know the HPCSA has in the past approved renal units. They've approved an emergency care that one could employ medical practitioners. Now it's possible you don't need their special permission anymore. So Ethical Rule 18 has been changed, and it would be possible for hospitals, for private hospitals, rehab units. Even I can decide here where I live, I'm going to employ all the doctors and the physios in this town. So it's possible. Employment is possible in that sense, but it would make this contracting much more simpler in the middle bucket, because then you contract as a single legal unit and you don't have to have a contract and subcontractors.
Oh, thanks so much. And just to allay everyone's fears, we are in contact with the HPCSA about many of these issues and some of the absurdities that can arise because of them. An important question here from Dr. Glass: surely the public service cannot accept any more patients, and the system of including private institutions is very vague. I think he speaks to the capacity issues that are currently faced in the public sector.
Yeah, so the capacity issues are well known, and I think that's one of the things that people have said in commenting on the proposals and now on the Act, is that we should, it doesn't help if we don't have the resources to make this work. If we don't have the resources to even fulfill the National Health Act's primary health care objective of free primary health care to all at point of care, perhaps we should take this a lot slower, and perhaps we should redesign how we do that, and go back to the initial plans that we had in terms of going to NHI through a social health insurance system where you actually leverage also medical schemes. You leverage the compensation fund. You leverage all of that to create universal coverage and have risk equalization between various funds, and then in the end create an NHI. We've short-circuited now what the initial plans was, and it means that we're risking so much in terms of human resources, for example. So yeah.
Yeah, another interesting question here about those patients that have rare or uncommon diagnoses, for which there are often not any guidelines or evidence. How will this be managed? And again, some of these questions, I suppose, don't yet have answers, but what do we foresee, Elsabė?
Yeah, so we don't know. So it is an important part of healthcare, and those patients are vulnerable. So from a constitutional law perspective, we must have a plan for that, because vulnerable people in the Constitution have special protection. So we need to consider how we're going to deal with this. And then how are we going to fund that? And are we going to create special funds? Other countries have special funds, carve-out funds, and so on. And we know we cannot do health technology assessment because the patients' numbers are too low. We've got issues in terms of just the medication and showing, you know, how it works, because there's so few patients with some of these conditions. So it's complex, and the same, even less complex things like bone marrow transplants and blood services. You know, how does that slot into the system? And you know, it is kind of specialized things and currently the difference also in terms of what's available in the private sector and in the public sector is also important, and how we're going to equalize this in terms of creating then evidence-based medicine guidelines and so on.
Yeah, a lot of unanswered questions. Who sets the protocols and formularies is a question from Dr. Murray. In less common but severe disorders, we have seen inappropriate recommendations in private and in the public sector.
Yes. And the benefits will be developed on the advice by that Benefits Advisory Committee that's in the NHI Act. And this is also one of the things where people made strong comments at the parliamentary processes to also say it cannot be the same 8 people, for example, that make that decision, because you need to bring in experts depending on what the specific conditions are. We need to make sure that the Benefits Advisory Committee does things according to evidence-based medicine. And that was another submission that many people have made, to say we're not protecting the principle of evidence-based medicine. And a lot of that could be scuppered by the pricing committee. You'll see there's a pricing committee as well. So it is going to be interesting to see how that plays out. And I think making sure that we have representatives, not only of doctors, but also of patients in these bodies. We must not forget the importance of patient voices in this. So the basic structures are there, but in the end, the final decision, and that was another criticism, is the final decisions that are laid at the door of whoever the health minister is at a particular point in time. That people say, but you know, this, you know, one shouldn't, all these technical details should not be put at the door of a single person to have the final say on the formulary or whatever. So I think it's the democratization, if I can call it that, of the structures that people were worried about.
Yeah, there's a comment here. I'm not anxious, I'm terrified. And I suppose when speaking about the pricing committee and knowing what we know about the price of skinny jeans in other circumstances, we really need to be very, very vigilant. And as you mentioned, it is concerning that many of these very, very important decisions come down to one man or woman's discretion. And yes, we might have a very good and ethical health minister right now, but one never knows what the future holds. And just on that point, another member says, in the COVID pandemic, millions of rands were stolen that were meant to procure PPE. How will the fund be protected from fraud?
Yes, so what we see in the structure on the National Department of Health's website, there is a specific fraud unit that will be put in place. But I think, you know, any system is only as good as its governance. And this is where people have spoken about the governance failures. If you put too many eggs in one basket and you drop that basket. And that's also why I raised the issue of provincial oversight. You know, if the Skinny Jeans Hospital didn't have somebody at the province who raised the alarm, so the structures must be built in such a way that we minimize. We'll never be able to exclude fraud and corruption, but we need to make sure the structures are set up in such a way that that is minimized. And unfortunately, most commentators to the bill through the process have said that's not the case. So if we are at risk, and we know history has shown us that, you know, the prosecutions in the end of just the PPE scandals and so on, we're not seeing those. So, you know, to hope that we'll prosecute and, you know, that will prevent, by then the horse is bolted. You know, you'd want to have a better system to prevent corruption from taking place. And unfortunately, our systems are currently in the hospitals and in various structures are not strong enough to actually make sure that it can't take place. There's still the possibility of it taking place. So that strengthening of these structures and having better structures in place is critical.
I mean, Elsabė, these all sound like very valid concerns and criticisms, not necessarily only complaints from well-to-do rich people, would you say?
Yeah, no, definitely. I think that was particularly, I think many people feel offended by that statement. If I, you know, the numbers of people that are using the private sector, the numbers of people that will be affected by this, the numbers of people that are currently affected by systems failures in the primary care setting that is basically an NHI already, save for the medical scheme members. I think we need to say that this is a genuine concern by people for the health system, and a concern by people who have done years and years of research from the Taylor Committee and from before that with the ANC health plan, who say, but hang on, things are not working and going in the direction as we thought it would. So we all want to end up at the same place. But I do find it, and I think many people find it offensive, that if you object against the NHI Act, you're seen as some rich, privileged person who just don't want to give up on what you have. Because there are many, many people who would be affected if a system fails. If we don't design a system properly and it fails. We have never made so many public hospitals components of national government. That's a massive thing. And if it fails, the risk, if we start transferring staff from the province at Kalafong Hospital, and now they are employed by Kalafong and no longer by the province, have we tested that? You know, do we know if it's going to work? If we say medical schemes can no longer provide X, Y, and Z, have we tested that? What's the research that underpins it? And the main thing is also the funding. The people that will be affected by the payroll tax, the bulk of the people in this country that will be affected by the payroll tax earn between 8,000 and 29,000 rands gross per month. That's the lived reality. Those are the people who will be affected by a payroll tax. And the question is, should we be putting that burden on them? And from that perspective, it's not, those people are not by any stretch of the imagination rich, but they will be affected. And I think we need to think about it not as rich people trying to cover for their own wickets.
Yeah, no, quite right. I mean, a comment like that just disregards all these valid concerns that we do have. And I mean, there's a clear lack of trust as well. And trust is earned. And unfortunately, the COVID pandemic and all the other crises have showed that trust hasn't been earned. And unfortunately, many of the submissions that we've made during the parliamentary process were also disregarded. We aren't raising these things for the first time now. But yes, back to a more practical question. What happens if a government institution, despite being perhaps the only health provider in a rural area, is not accredited?
So that was discussed in Parliament, and the solution was to accept provisional accreditation. So you will see in the Act that there's now space for provisional accreditation. So, and that also raises the issue as to, you know, we're kind of compromising then on quality, or we're saying access in spite of quality of care. I would urge people to look at the Office of Health Standards Compliance reports to see how many facilities have been inspected and how many have been accredited, because that's a big reality check. We need to address NHI or no NHI. We have to address quality of care. The Office of Health Standards Compliance are doing good work, and we need to support them. They're underfunded. And that's another thing. We cannot do this if they can't do their job faster. But the parliamentarians just made a change and said it's also possible to be contracted if you are provisionally accredited. So in that rural area where there's a provisional accreditation, the NHI could contract with that entity.
You've touched on some of the quality concerns. Dr. Lover raises a very interesting point about the reports about the NHI pilot sites. Perhaps a euphemism, but he or she says, I understand that there were compliance issues. Has a follow-up been done to see if corrective action was done in these facilities? Elsabė, your take on the pilot sites?
Yeah, I don't know if corrective action has been taken. What I can tell you is in the Office of Health Standards Compliance, if there is non-compliance, they want the facility to submit remedial plans and to act on those plans. And it's either in last year or the beginning of last year's report, it was said that the National Department of Health would help these facilities who are non-compliant to become compliant. So they have to submit these remedial plans and then take action on it. But it did seem from the Office of Health Standards Compliance reports that that is not totally satisfactory, and that help would be needed in that regard. So just on that, and I think if we have to focus on elements of NHI that we in any case have to do, this is one of those things that we have to do. It's like the way in which we practice, the way in which we organize ourselves. We have to do something about that. We have to do something about fees and costs and risk sharing and all of value-based care that we have to do. So for me, quality is another thing that we have to do, NHI or no NHI. So we need to address these non-compliant entities and the remedial steps that they have to take to become compliant.
Sorry, I am peppering you with questions tonight, but as you can see, there are a lot of questions from the members. The certificate of need, will it be part of NHI, and where are we currently on the certificate of need?
Okay, so the certificate of need is in court at present. Everybody has filed papers and heads of arguments and all of that. We'd need to hear, there will be a ruling, therefore depends on how fast the judge rules on it. But I would hope before the end of the year we'll know. The interesting thing is that section that I've shown you on the accreditation, that mix and number of healthcare professionals, that's verbatim what the certificate of need also is. So many people are saying, depending on how the certificate of need case plays out, it will give us an indication as to how a court may rule on that accreditation criteria, those specific accreditation criteria. So the certificate of need case, I think, is a really important case. It's also an important case because it deals with the issue as to if one can challenge something that's not in effect yet. So that will also be raised. So in my view, the answer is yes, you can, because it raises constitutional issues. We don't need to wait for something to happen and then only can we say, oh, but now people's rights are being affected. Because with a certificate of need, for example, if you don't get a certificate of need for a particular area, it does mean that you need to find yourself a different area. Or as they argued in the papers, it was argued that, you may just need to change your area of what you're interested in. So if you're a shoulder surgeon, perhaps you must do a bit more knees, and then there may be space for you as a knee person. So I think this is why that case is being watched so closely, because of the similarities with the NHI criteria. But of course, the fact that it is being fought means that the intention is to implement the certificate of need at some stage. And I think, yeah, and because if it wasn't going to be implemented ever, it would be of no use to challenge it or to defend the challenge, I must rather say.
Dr. Kwabi raises a very important point and question, and I suppose this is something that will come up in the constitutional challenge around whether these changes are justifiable in terms of the Constitution. He says the reality is that there are still huge inequalities in terms of access to care, especially specialist care. If one takes an example of oncology care, the situation is desperate for patients who are not covered by the medical aid. The reality is that I have never heard of an alternative remedy to this inequality. So it's a stark reality and something that will definitely be raised in court. Your response to that, Elsabė?
And I think this is a very important thing, is that there are various ways. There's not just this way, and people have put those ways up. This country have researched those ways. So it's not as if this is an all or nothing thing. There are various ways in which one can achieve universal coverage. So there's not one answer, and it's not as if there wasn't a plan and there wasn't research and people haven't acted on it. There's been a lot of research. There was a plan. We had medical schemes, and risk rating came into existence because of the previous plan. So, but then we somehow stopped implementing some of the reforms. And if anybody wants to listen to Christoph Rath's presentation at the BHF conference, he unpacks that quite nicely. As to we have at some stage said, no, we're no longer doing this. we're now doing it differently. And then we sat with half implemented things. So it's not as if there's never been any other proposal or any other research or anything. There's been a whole commission that was chaired by Prof. Vivian Taylor on social security systems that looked at compensation fund, road accident fund, the health system, all of that. So it's not as if we didn't have anything, and equality, the lack of equality, the inequity got worse and worse. And I think what we did fail as a nation is we didn't implement the things that we should have been in. If we talk about national health information system, it's been in the law since 2003. Okay, so why haven't we done anything about that? So there's many tools of transformation and tools to increase equity that we haven't used. So, and nobody's saying the private sector is perfect and the public sector is also not perfect. And the private, we have to intervene. This is why I'm not saying we must sit back and just defend at all costs the status quo. The status quo is not the future.
No, and I mean, unfortunately, this regulatory and policy vacuum that has existed around stuff like the HMI has created this environment that unfortunately is conducive to some of the things that we've seen. And it is really unfortunate that NHI is now held up as the mechanism when it has so many flaws. And to that point, Dr. Pillay says, SAMA should now also concentrate on developing alternative cost-effective service plans and models that will challenge the state service delivery model. And I think that's a very important point. And I'm happy to say that this is just the first in a series of these webinars, and the work is ongoing. We aren't putting all of our eggs in the legal challenge basket. We do have to be very agile and be able to adapt to the policy environment and the interests of our members, and we shall do that. Just here, a question on the pricing regimen. Is it lawful for the government to set limits on pricing of a trained profession to sell out their skill in an open market? We have not seen this in any other way or industry. No artists are the same and no doctors are the same, hence the different rates.
Yeah, so this is
a very interesting argument.
and it's one of the most controversial things. And remember, it's also one of the recommendations of the health market inquiry is that we should create some negotiation mechanism. Now, I worked for SAMA in the initial days when we were doing collective negotiation and got fined. So, but it was a recommendation that we need to think about, and there's a difference between price fixing, price setting, and price negotiation. I think people feel price negotiation that's underpinned by some scientific basis is much more acceptable. And we do have indications based on the Minister of Finance speech beginning of the year that people are re-looking at the reference price list system. And that's something that is currently mandated in the National Health Act. So, and reference pricing is also not price fixing or price setting. So I think one should watch this space, but I feel very uncomfortable with price fixing because it does in the end affect one's property rights. It does affect your professional rights. So it is something that one needs to be careful. And I've lived also through the pharmaceutical pricing system. And now that treatments are complex and for rare diseases, the fixed price system is no longer working. So I think we need to look at models of reimbursement that is different and innovative. And there's lots of work that's happening and lots of models and examples on that, and value-based care. So we can outcomes-based care, risk-sharing models. The sky's the limit. So I think there's alternatives to price fixing. Because remember, every time you fix a price, somebody must check that the fixed price were actually the price. So it creates a whole administration and a cost that one wouldn't otherwise have.
An interesting question here, Elsabė, about the reserve funds that the medical schemes sit on. What will happen to that pot of money?
I have no idea. I have no idea. And we know that scheme solvency it's looking very good. It's looking a bit worse last year than the previous year, but it is still way above the 25%. So I think I'm not sure. But I think medical schemes are not too worried now. They're worried about the principle because of that provision that says only once the NHI is fully implemented. So, yeah.
Yeah. Question here from Dr. Klali. He's interested to hear about what happens to pathology services with the implementation of NHI. Will they be charging from the fund? Will there be one lab or multiple labs?
Yeah, it's also a brilliant question because it's one of those things that, will they be in the same package in that middle bucket with the hospital and the specialist? And where does the NHLS fit in? And will pathology firms contract in competition with each other and with the NHLS to render pathology services, or it's not clear. So it's one of those things that, we don't have a clear answer for. The other really interesting thing is, remember, pathology is not just a secondary or tertiary or quaternary discipline. It's a primary care discipline as well. So it's one of those ones like the orthotics and prosthetics that also spans all three buckets. And I think those models, haven't been worked out. What we do know is that there's work being done currently on DRGs. So the diagnosis of a condition would be work into the diagnosis related group. And those costs would need to form part of that. So, but yeah, it's not clear.
Yeah, unfortunately, that's an answer to a lot of these questions. Another interesting one here, as a specialist, can I open my own cash private practice outside NHI institutions, which will work like any private business?
That would be a possibility. So if it's not funded by a medical scheme, that would be a possibility that somebody could do that. And remember, the Constitution gives people the right to have social security mechanisms. So the one that South Africans know is a stokvel, oorgooi. So we can start a health stokvel, and that's not prohibited by the NHI Act. So it would be possible to do that, to kind of have alternative structures, because the Constitution does allow for people to create social security or to be part of social security mechanisms.
Dr. Beaton touches on a very sensitive topic, indicating that the true tragedy is that there is so little faith in the ability of a DOH to lead implementation of NHI that we are again losing the cream of the young generation of doctors who have recent experience of how DOH works. Yeah.
And I think that's perhaps also a question for Sama, because you guys have done the research and you know what the feeling on the ground is. Yeah.
Yeah, and unfortunately, not a lot has been done to allay some of these very valid fears, and just dismissing them as well-to-do rich people complaining doesn't really do much. Another question here. Sorry, I'm just taking some question from the other social media platforms. Dr. Mpunga via LinkedIn asks, is there any clarity regarding transitional arrangements? That's a tough one.
There is a clause that talks about transitional arrangements that in broad strokes say we have to amend a whole bunch of laws. We'll do this in 2 phases. But really how it happens that Tembisa Hospital gets from out under Gauteng and become a national component of government, that we know it happens in terms of the Public Service Act. But exactly how that's planned and what that would do to employees and to patients, I'm not. I haven't seen any roadmap for that. It's a labor issue. It's a patient care issue. It's also a procurement issue because they still need to not procure skinny jeans, by the way, but procure the right things that's needed by patients. So that those plans we haven't seen any of those. And I think knowing what those plans are would make healthcare professionals feel a lot more comfortable in terms of how this will play out. So we get told that don't worry, we'll do it in bits and pieces and we'll do it in phases. It won't happen all at once. But people are skeptical and there is a trust deficit. And therefore people are concerned as to how we're going to do it. What are you going to do with the contingent liabilities, the medical legal cases that sit in a province? People need to know that and they want to know how that's going to play out. How are we going to compete in HLS and private labs, for example? So I think these are valid questions.
Another interesting one here from Dr. Human. So diabetes and hypertension are one thing. Open heart surgery is quite another. Now, can the state that already cannot service current needs of the population deal with larger, far more costly issues? Surely there is no way to disallow treatment of these in the private sector legally.
Yeah, so it's really interesting also these higher cost procedures and complex procedures, that there's a mix of technology and human resources and where the skills are and how people are then accessing them. So the problem legally is that the NHI Act gives people rights to comprehensive care. Okay, so there's no staging of that right that is granted to people and that definition of comprehensive care. And I think that means that somebody could, in terms of that complaints and appeal system, go all the way and talk about their rights that's been granted by this act not being given effect to. And that's also the last thing that anybody wants, is a heap of cases through that chapter and through that appeals tribunal to say, you know, I need my pig kidney now, you know, or whatever. So the way in which the act is drafted gives people actually quite strong rights. And I think that people will exercise those rights and would then say the state must pay for it at another entity. Again, that NHS presentation from Prof. Hendricks at the BHF conference was quite revealing as to the phases of the NHS. And then they bring in private providers, and then the private providers, private insurers, and then there's cherry picking, and then the GPs are gatekeepers, and then they're not gatekeepers. So I think for me it was revealing to listen how these things would then ebb and flow. But the last thing that we can have, and remember in the UK, they don't have a constitution that gives people the right of access to healthcare. We've got it here, and we've got this right entrenched now in the National Health Insurance Act. So, yeah.
Elsabė, just to get back to SAMA's legal challenge, when do we foresee those papers being filed? How do we foresee it going? What will be, and we can't give away the legal strategy, of course, but what would we base the challenge on broadly?
Yeah, so it is basically a constitutional challenge, and I think as everybody's challenges would be about. But we will file when we're ready to file. And as you know, these cases are complex because it's not just my view or the advocate or the attorney's view. It is also the SAMA view that's important, because this is not a theoretical thing about what me and Tatu and Carl thinks about access to healthcare and so on. This is actually about SAMA's members' interests and the patients that you care for. That's what this is about. So we're taking our cue very strongly from the interests of the constituency, and I think that is what one should be doing. We can do a whole long theoretical thing, and I think in particular our advocate every now and again brings me back to say, yes, we see that is an issue, but that's perhaps not our fight. So, and this is also why I think a single case, we cannot make the case for the OMPs. The people in orthotics and prosthetics, they have a different lived reality than yours. And although we can envisage how their work influences doctors' work, that case is not our case to make.
And I mean, a very difficult question, and perhaps we'll end it off on this one, from Dr. Howarth. With all these legal challenges, what does success look like?
I think so. We need to get back to a transformational discourse and a transformational course that will lead to access to healthcare, that will not throw the baby out with the bathwater, that won't scare people, because this is the thing, people are scared. So we need to create for people not to be scared. Our constitution says rule of law, and it says legal certainty. We need to know how the law will apply, how things will play out. So, but we need to get back to what are we going to do that is realistic and practical in terms of realizing the right of healthcare for all in this country. And I know many people don't like that illegal foreigners should not get care. They're here, you know, and ethics say we should be helping them. You know, the women with a baby who's sick, I'm not sure there's many doctors that will turn them away. To say we're only treating the TB but not the HIV patients is also so we need to get back to what would be our course of action to increase access to healthcare. Universal coverage is not equivalent to NHI. There are many models of this, and there are ways in which you can move from model to get in the end to perhaps a single fund in future. But now the country can't. So I think we need to perhaps all dust off our old policy papers and the research that was done, and also modernize this, because there's such exciting things that's happening in terms of multidisciplinary practices and cooperative care and leadership in healthcare and funding models and you know, models of being reimbursed for performance and outcomes. We need to embrace all of that.
No, thanks so much, Elsabė. It's been a wonderful presentation. I just from my side want to say, in these challenging and uncertain times, I think it's more important than ever that we stand united. Get in touch with your branches, get in touch with head office, speak to us, speak to your colleagues, and let's have our voice be heard. And of course, SAMA is here to support you, no matter how this progresses. And I see a lot of names have joined us here that I haven't interacted with. Please give me a call or send me an email. I'd love to chat to you, even if you don't have an issue. And yeah, with that said, thanks so much, Elsabė. Thanks so much, everyone, for joining. I'm going to hand over to our CEO, Dr. Norikida, to have the final words. Thanks so much, everyone.
Thank you very much, William. I hope I'm audible, colleagues. So I would like just to stress that the South African Medical Association, given its purpose, it was formed to unite doctors for the health of the nation. So we remain firm in our commitment of championing health and the well-being of all South Africans. And we remain resolute in our endeavors to actively participate in the realization of UHC, which is universal health coverage. We're also aware that this is a global goal. So SAMA is not opposing universal health coverage. But as an organization, it is also our duty to advocate for equitable access to affordable and essential health services as a basic human right, and to ensure that there's highest achievable quality health outcomes in the country. We are and we will always devote ourselves to this, because we also understand that every dollar or rand that is spent on healthcare is in fact an investment. Research has shown that countries that actually thrive from an economical point of view, those have generally very healthy populations. So we are acutely aware that rand spent in healthcare is in fact an investment. And we've been very clear in our various engagements that even though we support the overarching principles and the objectives of the NHI, but in its current form, it really fails to address the country's complex health issues. So we just cannot support it in its current form. The Act, it's no longer a bill now. So, as representatives of medical professionals in South Africa, SAMA remains committed to engaging constructively with government and other stakeholders within the sector to develop a comprehensive and an effective healthcare system that prioritizes the needs of patients and healthcare providers alike. And in closing, colleagues, we call upon all like-minded stakeholders within the sector to stand with SAMA to take this matter forward. We also call on government to reconsider the NHI Act, and in fact, in consultation with healthcare professionals and experts, which we have in South Africa, to ensure that it aligns with the principles of universality, equity, and sustainability. We want to also thank our members who are in support of our organization, championing their rights and those of our patients in healthcare-related matters. SAMA stands ready, I want to emphasize this, to collaborate with all stakeholders, including government, to achieve our shared goal of a healthier, more productive, and a more equitable South Africa. So I want to take this opportunity and thank everyone who has joined. This is by far the largest attended webinar that we've held as an association. So we want to thank you all for taking the time. Thank you very much, and this will be made available in our YouTube channel. So thank you very much. Thank you.